like to call upon stage. I would like to call upon stage our first session of our speaker, Dr. Dhiruba Jyoti, Dr. Shyamanta Das, and Dr. Prasanjit Ghosh to come on the stage with our honorable chairperson, Dr. Sharmila Sarkar, for chairing a session on the topic of evidence-based interventions for autism spectrum disorder.
Will speak on the recent development in management of autism spectrum disorder. Evidence-based approach to autism spectrum disorder. The first speaker is Dr. Dhruva Muya. He will speak on pharmacological management of ASD. And then we have another speaker, Dr. Shamanto Das. He will speak on behavioral approach to ASD. And Dr. Prasanjit Ghosh, he will speak on caregiver training and caregiver training. Okay, so we all know that the autism spectrum disorder, the prevalence of autism spectrum disorder is increasing, and we have to detect the autism spectrum disorder earlier so that we can manage them effectively. So please start, Dr. Dhubajyoti Muya.
Thank you, Madam. Respected Chairperson, all the delegates present here. Today I am here to talk on evidence-based pharmacotherapy of autism spectrum disorder, and it's not working. Did it work?
This is not working.
Manual one. It's hanged. It's not working. Will it work now? It's hanged. Now it's working. No, not working. No, they will give it from the podium.
It's working? It's working, sir?
Yeah, now it's working. Yeah. Okay. Now, when we talk about evidence-based pharmacotherapy of autism spectrum disorder, why we need to talk about this is that of late there have been increased number of cases being detected with autism spectrum disorder. And therefore, we need to do something for this group of people. And therefore, there is definitely a demand on effective educational and therapeutic services, and there are many services which are thought to be available. But what we will be talking about is the evidence-based practice. When we talk about evidence-based practice, means as we are shifting from what earlier people used to call it as trial and error method, suppose giving one medicine to someone will respond or he or she may not respond, to be more precise towards the precision medicine. And now we are in between these two ways, and that is what we call is evidence-based medicine, where the evidence of efficacy has been shown with certain researches. There is a famous saying in medical science that every clinician should have a good clinical judgment, and good clinical judgment comes from experience, and experience comes from bad judgment. And now in this era, we cannot wait for that bad judgment so that we can develop a good clinical experience or good clinical judgment. So we have to focus on this evidence-based medicine. And of late, there have been a paradigm shift regarding the treatment or the management of this autism spectrum disorder, where the medical model has been shifted to the social model, where we don't see the person as a problem, but our main focus is integration of that person into the society so that the disability is minimized. Therefore, the role of the pharmacotherapy is only one aspect. And if we look into the treatment approaches, then these treatment approaches are therefore multisensory, multidisciplinary approaches. And mostly, as we are shifting towards the social model, the established therapies are mostly non-pharmacological, which will be spoken by my subsequent speakers. And till date, no pharmacological agent is found to be effective for the core problem or the core manifestations of autism spectrum disorder. When we talk about evidence-based medicine, then these are the different levels of evidences, and the researches are quite limited on the options, and we'll be focusing few of those studies which have shown the efficacy or the inadequacy or the side effects of the medicines which are being used. One should be very much clear that till that there is no medication which is approved by US FDA for the treatment of the defining features of disorder. Only few medicines which are US FDA approved are only for some of the target symptoms, but not the core symptoms of autism. These target symptoms might be the harmful behavior, repetitive behavior, poor attention span, then aggressive behavior and self-injurious behavior, or even the sleep disturbances, and sometimes even the comorbidities can be the target symptoms. Therefore, the pharmacotherapy which is being applied is directed towards these specific target symptoms or the comorbidity only. To sum up everything, actually, this topic can be summed up in even one slide, where we can say that the second generation antipsychotic, mostly risperidone and aripiprazole, These have been approved for certain behavioral problems in children. But we have got many options like antipsychotics, both typical, atypical, then comes the anti-epileptics, alpha-2 agonist, and naltrexone. Then haloperidol. If we look into the efficacy of haloperidol, there are studies which have shown that the behavioral symptom improvement is definitely there if we measure it in terms of children's psychiatric rating scale. But risperidone, it is the US FDA drug for the age group of 5 to 17 years, and it has shown that significant positive finding on hyperactivity as well as stereotypy. Aripiprazole is another drug which is being US FDA approved for irritability in children and adolescents with autism. Usually this aripiprazole is safe and well tolerated, and when it comes to the olanzapine, there is few studies which have shown that olanzapine has shown some improvement in the global functioning as compared to the placebo. If we sum up the few of the findings of various studies, then we can have a glance there where risperidone is found to be effective, but again, olanzapine has shown certain global improvement, then ziprasidone has even been tried. For the symptoms of irritability and problematic behavior, there have been various reports, various studies, meta-analyses which have shown that risperidone and aripiprazole are found to be quite effective. When it comes to the mood stabilizer, then we have got the anti-epileptic group as well as the lithium. One non-blind trial with 14 patients involving valproate, it has been shown to ameliorate the symptoms of irritability, but there are other studies where it has shown that valproate reduces repetitive behavior and irritability. If you look into this, then valproate has shown some amount of improvement in open double-blind placebo-controlled studies, but oxcarbazepine has shown improvement only in certain case series, while levetiracetam and lamotrigine have shown to have no much improvement, while topiramate has been shown to have improvement only as an add-on, that too in case series. Similarly, lithium in case series has shown improvement. Other medicines which have shown some amount of improvement are arbaclofen, butamide, and N-acetylcysteine. When it comes to the SSRIs, the Cochrane review says that the decision of using SSRIs should be case by case. And then it comes to the ADHD symptoms where methylphenidate has been tried and it has shown to have improvement in case of hyperactivity, impulsivity, and disinhibition, but the caution is that at least 66% of the children has experienced at least one of the side effects of these medicines. Therefore, it has to be used with caution. Atomoxetine has also shown some amount of improvement. When it comes to the SSRIs for OCD kind of symptoms or repetitive behavior, then fluoxetine has shown to be improvement. Then people have tried with citalopram and escitalopram, but results are unequivocal. Then there have been researches on the core social impairment symptoms, and few medicines have been tried, like acamprosate, oxytocin, memantine, and dicycloserine. Regarding use of acamprosate, this is an ongoing trial, but the results are still weighted, but it has shown that the medicine is well tolerated. Then oxytocin is a promising option, but it is too early to comment on that. Then memantine. Memantine has shown improvement only as an add-on to other psychosocial interventions. D-cycloserine has also been tried. The clinical trial, it is still not out, but they have said that it is often tolerated. Then clonidine. Clonidine is effective in reducing the sleep latency as well as night awakening. Then comes the naltrexone. Naltrexone, the findings are quite interesting in the sense that there have been the initial worsening of symptoms when it was started with 1 milligram per day, but when it is started with 0.75 milligram per kg per day, there was some improvement in, at least in self-mutilating behavior. Then nowadays the people are trying with L-carnosine, and L-carnosine has shown significant improvement in Gilliam Autism Rating Scale, but they have said that the exact mechanism is not known. Moreover, when this L-carnosine was given as an add-on with risperidone, there was no difference on irritability subscale, but there was improvement on the hyperactivity as well as non-compliance subscale finding. N-acetylcysteine, this is again a case report only, where it has shown some amount of improvement. And this is the trial where it is said that the N-acetylcysteine is well tolerated by the children. Till now, what I have said, this is the executive summary of everything. The interested audience can have a glance on this. Then this is our own IPS guideline. And I am giving a sum up of this IPS guideline here, where the medicines which are given for distress, anxiety, and agitation may be clonazepam, lorazepam, even aripiprazole. Then, for depression, what our IPS guideline has said is the SSRI, TCS, and stimulants, and for bipolar disorder, valproate and lithium. These are the recommendations by our IPS. Then if we look into the summary of everything, then for the pharmacological treatment, then risperidone, aripiprazole are US FDA approved for the behavioral problems, then SSRI is for anxiety, and comorbid symptoms should be treated on its own merit. There are certain other therapies which are not recommended, and of course, few days back, this is how IPS has given its stand on or the position statement on stem cell therapy, where these are not recommended. So, this is my last slide, where it has been said that the clinical evidence of pharmacotherapy for autism spectrum disease is limited. Spectrum disorder is limited. There are many adverse events, and therefore the clinician's judgment is of utmost importance. Thank you.
Respected chairperson, my co-speakers and esteemed audience, In this symposium on evidence-based intervention for autism spectrum disorders, I'll be speaking on educational approaches, behavioral interventions, and psychotherapy. Myself, Shyamanta Das from Guwahati. To begin with, the goals and the base. The goals in the treatment of autism spectrum disorder is to promote learning and at the same time to eliminate behaviors which can impair the learning process, that is, the disruptive behaviors. And while targeting the learning process, we need to stress upon development of language skills as well as communication, at the same time, skills for individual help. How this can be achieved? It is based on a program which has to be structured and individualized and has to be carried out with a comprehensive assessment. And in this comprehensive assessment, we need to identify not only the strengths, but also the needs of the individual. It is important that the professionals have experience in working with individuals having autism. At the same time, various professionals has to be utilized. These include speech and audiologists, at the same time occupational and physical trainers, also special educators. Evidence shows that as early as possible, we should start the intervention, and it needs to be regularly updated, taking into context how the treatment is progressing, what is the age and developmental stage. For example, in adolescence, our stress will be on acquiring the vocational skills like taking care of the individual self-needs. If it is a Rett syndrome, then we may have to include other professionals like respiratory medicine specialists, even orthopedicians. Coming to the main approaches, to start with the educational one. It has to be intensive and very structured. In classroom, those who are highly functioning, just supervision may be sufficient along with support. But those who are lower functioning, intense involvement of the teachers will be required, as well as in the classroom, the less ratio between teacher and the individual is more beneficial. For the lower functioning, we need to look into the fact that how much they tolerate the supervision by the educator or the teacher. At the same time, we also know that these individuals like to follow strict routines, and these routines can be utilized for giving them systematic therapies, which will help in acquisition of communication skills. And the learning should be progressing from associative ones to the conceptual-based learning. These individuals are very easily distractible, so we should look into the fact that the classrooms should not have windows and the walls should not be highly decorated. Moreover, this effective routine can be utilized for systematic learning. Individuals, once they learn the skills, has difficulty in applying them in new situations. So it is true that we should look into the fact that once the skills are acquired in classroom, they are generalized in other settings as well. Speech and communication is our main focus for the skill development, but those who are poor in that, we can use non-verbal communications as well, which can be in the form of sign language, even picture exchange. But that does not mean that in these individuals, we will not be giving stress on acquisition of speech and language. For the higher functioning individuals, we target social skills which has to be acquired not only, but also it has to be generalized, not only in high functioning, but as the child grows older. Teaching methods should target problematic situations. They should be specified. Rehearsal and social scripts can be an useful tool in that. Explicit problem-solving approach is advisable in naturalistic situations. We can have small groups as well as individualized one, and again here to reiterate that it needs to be generalized, not only in classroom, but in real-life situations and new settings as well, which can be achieved by modeling of the behavior, even videotaping one's self-behavior and looking at it, then role-playing, and exchange of stories of one's social interactions can be useful. Coming to the behavioral intervention, the approach is simple, that we want to promote the desired behavior and we want to eliminate the problem behaviors, which is based on the learning theory principles. And the technique used is behavioral modification. This behavioral intervention has to be integrated with the educational approach, which will help us not only taking care of the disruptive behaviors, but also in acquisition of cognitive skills like vocalization as well as speech. First, through a functional analysis, we try to know which are the target behaviors, that is the disruptive behaviors. Then we also identify the reinforcements. And after that, through the behavioral principles of shaping, prompting, and extinction, we try to develop alternate behavior. And after that, we want to maintain that with mature rewards. About the psychotherapeutic approach, it needs to be structured and supportive and useful in case of higher functioning individuals. And again, it should be explicit problem-based. As the individual grows older, they see their own differences and difficulties compared to the rest of the individuals, which can lead to emotional symptoms like anxiety and depression. And here, individualized psychotherapy to deal with these explicit problems can be useful. They should target the problems. It should have a problem-solving approach for better adjustment, at the same time, self-satisfaction. Let us keep in mind that insight-oriented approach is of no use. So is the psychodynamic psychotherapy, and unstructured play therapy have no role to play. Among the newer approaches, modified cognitive behavioral therapy, which has to be specified to the individual, is one such one approach. In Goosebumps, Jack Black says that every story has a beginning, as we discussed, a middle part that we also discussed, and a twist. If we look into some contemporary developments in psychiatry, there is the work of Matsuri Kesavan and his colleagues, the BSNP. Then Thomas Insel and his team's work on research domain criteria. Then Joseph Johar and his team's neuroscience-based nomenclature, and what Stephen Stoll says, deconstructing the symptoms into the respective brain circuits. What we can see that these developments leading us in two ways. One is a brain-based diagnostic system, and another, the therapies are classified instead of category to mechanism. For example, we all know that, say for example, escitalopram we are giving to a patient with depression. Another patient with anxiety disorder may come and question us why you are giving an antidepressant for my anxiety disorder. That shows why we need to move to the mechanism-based approach. And in between lies the journey of psychiatry from phenomenology to neuropsychiatry. Our current diagnostic systems, both ICD and DSM, can be compared to the TNM classification, the tumor node metastasis classification in oncology, which in fact nowadays is moving to specific human epidermal receptor growth factor, HER1 and 2. In psychiatry also, we can promote such an approach, which can be called personalized medicine in psychiatry. And in our journal, OZIPAS, the Open Journal of Psychiatry and Allied Sciences, in one of the cover, we also stressed on that. For example, a newborn makes new parents very apprehensive how to take care of the child. They take advice from relatives, neighbors, general physicians, pediatricians, but as time grows old, the child grows older, the parents realize that every child tells their own story. The need has to be individualized, specified. For example, even a diagnosis of schizophrenia doesn't help us much as far as management is concerned. What we need to do is, first, we need to have a diagnosis. Then, we try to deconstruct the diagnosis to its respective symptoms. Thereafter, we try to know what may be the malfunctioning brain circuits involved producing these symptoms. And with our current knowledge of the therapeutic approaches, we choose a tailor-made treatment, that is the personalized medicine. And such an approach in autism spectrum disorder can also be used, and here becomes useful tools like INCLAN, later modified by All India Institute of Medical Sciences and ISA, where we have a symptom checklist, and according to the symptoms present in that individual, we tailor-made our non-pharmacological approaches. Thank you.
A warm good morning to respected chairpersons and the esteemed speakers. I will be talking on the caregiver training. ঠিক আছে? I told earlier, no?
हाँ सर इंटरनेट तो एखाने किछु करा नहीं सर एटाई तो मुश्किल सर वायरलेस डिस्प्ले कनेक्ट देखो सर अपना ब्लूटूथ এটা কি
Vivo 1706
সার্চ করছে এখনো প্রণব একটু হলেতে আসবি প্রণব হলেতে আসবি স্যার একটু এটা কানেক্ট করে দিই নাহলে আপনি শুরু করলে তখন কানেক্ট করা যাবে না হ্যাঁ হলেতে একটু আয় ইন্টারনেট কানেক্টিভিটি লাগবে ল্যাপটপের সঙ্গে আয়
কত টাইম লাগবে
Position display C. Digital display. Find the type of device. Find the type of device.
He's taking time for some technical problem. This symposium we actually planned with all the speakers from Assam. Myself working at Silchar Medical College, Samantha at Guwahati Medical College, and Dhruva at Assam Medical College, Dibrugarh. We are trying to build a team for this purpose, and I hope you have enjoyed both the speakers, earlier speakers' talk. Basically, this my part, I will try to focus on how to take care of the caregivers, because the caregivers of autism spectrum disease patients, they also have lots of psychological problems, and there are lots of issues which we should take care of. So I think we should go without your...
Okay, sir. We just start.
So what are the dimensions? Whenever there is a childbirth, a parent is born, and there are some problem maybe in parental relationships, and there are some problems what will happen to the child with ASD when he or she attains adulthood. And there are lots of recent problems, like nowadays we have lots of single parents, same-sex parents, step parents, adoptive parents, and the family is getting smaller and smaller and smaller. We do not have much of extended family. So these are basically the dimensions I'll be talking on. So as the infant emerges, there are also two births. A lady becomes a mother and the man becomes a father, and the family is born. And this experience of parenthood changes us forever. But the bad news comes at the time of second birthday, when the baby is no longer playing normally. So what is the impact of the diagnosis of ASD on the families? Obviously, there are greater distress, a sense of hopelessness, a sense of self-fulfilling prophecy. There may be even marital conflict because of lots of adjustment that is required to handle or to cope up with a child with special need. Even there are greater stress for the single parents. And poverty, low education level, and psychiatric illness in the family makes it harder to cope. So what we should do? Before putting the mask, we must take care of the health of ourselves. That is, the caregiver should also take care of their various problems. They should be aware of the what are the stress and how to deal with that stress. So what are the strategies? The parents should listen actively to their children. They should not ignore or they should not stop their children from asking questions. Rather, they should facilitate questions. And they should extend the question. If the child says ball, the father or mother should say, what color? What color? What is the color of the ball? Red ball. So the parent should extend the question, and by that way they can help in verbal development of the vocabularies, development of the communication skills. Look for the things the child enjoys. Don't have very high expectations, have realistic expectations. And select activities and toys that help in interaction and that need interaction. Suppose the child likes this toy, you hide it. Let the child ask for that toy. The play should be interactive. You should not give such toy to the child where there is no interaction is required. And try to divide the caregiving responsibilities. Father will do something, mother will do something, sibling will do something, grandparents will do something if there are grandparents in the family. And always appreciate, acknowledge accomplishments. And it is not always a fact that someone will enjoy or would like to stay with a child or an adolescent with some disability. But if a father or a mother can enjoy or can share time with their child with different type of abilities, then the bonding and the relationship will improve. Because that control we have, we can decide that we will give time to our children with special need. Acceptance does not mean giving up. It means that we would take some alternative options. It does not mean that we are accepting failure. It does not mean that we are resigning. It does not mean that we are giving up on life. Acceptance is about widening, finding newer strategies, finding newer alternatives, and opening up oneself. Life is nothing but balancing act. We'll have to balance and we'll have to find ways to be happy and to make others happy. So, to be happy, we don't have to be normal. What I mean to say is, a parent can be happy with a child with special need also. It does not mean that to be happy, your child has to be a doctor or engineer. You can be happy with a class 8 pass child also. It depends on the perspective. So what should a parent do? A parent should be informed about various helps, various kind of NGOs, various kind of helplines that are available to get information. They should participate with other stakeholders. They should be aware of the evidence, protocols. They should share their knowledge, the strength of their child, weakness of the child, the strength of the family, the skills of the child. and they should cooperate with the team, and they should celebrate success of the team also. So this is the home. What are the problems in the home? What I mean to say is how to train the caregivers in the home in comparison to the clinic setting or the child. Because the home, you cannot control the variables. In the child or in your clinic, it's a structured environment. The home, there are so many variables, and the child is known to the environment. And in the home, there may be competing demand. You are giving training as a psychologist or a psychiatrist. The parents may ask the child to take some food. So there are competing demands in the house. And the child has a history in the home. He knows the home. But in the clinic, it is different. This is a novel setting, very limited history, and expectations for relationship between teacher and student or client and provider are quite different. So who is a caregiver? Cambridge Dictionary says a person who provides direct care. According to US legal system, a primary caregiver refers to the parent who has the greatest responsibility for the daily care and rearing of a child. Parents of children with ASD experience higher levels of stress when compared to parents of typically developing children. And the coping depends on personal characteristics, the child's characteristics, the family and social support system, and many other variables. There have been reports that high levels of parent stress can counteract the effectiveness of early teaching interventions in children. That means we are giving intervention as professional to a child with ASD only, without taking any care of the caregivers and parents. So the benefit of this training that we are giving to the children will be minimized or maybe nil also by the inattention that we are giving to the parent. We are not taking any care of the parent, and that parental stress will negate the positive effect of the training that we are giving to the children. Increased parent skills allow child to learn in a different situations, in various situations and environments. And the parent training is now considered an important component of successful programs. Parent training is defined as an effort that aims to enhance or facilitate parent behaviors that will influence positive developmental outcomes in their children. This parent training helps parents teach skills to their children and also help them to regulate their emotion and manage problem behaviors in their child. It differs from psychoeducation. Psychoeducation is passive, is very limited. You just say that this is schizophrenia, your son has to take long-term treatment. That is psychoeducation. Parent training is more active, more interactive. You train the parent how to regulate their emotion, how to feel good, and then how to train their children. So parent training is much broader. Following intensive treatment, children whose parents were trained on the intervention continued to improve, as opposed to children who returned to an institutional setting and lost the previously acquired skills. Two groups of children, both were treated with intensive treatment. One group continued to get training of their parents, and in other group, the children's parents were not given any training. So this group continued to improve, and this group showed deterioration. So when we train parents, we can begin the intervention as early as 2 years of age. By supporting the child in establishing shared interest and learning the power of imitation, parents act in a synchronous way with the child's focus and intentions, and language and communication are enhanced. Many teaching approaches exist and programs differ in mode of treatment delivery. therapeutic components provided, and targeted recipients. Types of treatment. Most parent training programs tend to address core symptoms of ASD and also problem behavior, sleep disturbance, feeding problem, etc. Parents can be taught skills that relate to managing their own emotions, cognitions, and behavior. Programs designed to actively engage the parent in promoting skills acquisition or behavior change in the child. Parent-mediated interventions can be divided into two parts, primary and complementary. In primary programs, actively engage parents to facilitate the child's acquisition of specific skills or the reduction of maladaptive behavior. But in complementary program, initially involve the child and the therapist, initially, and then parental coaching. So, complementary is better. Complementary programs include the early start Denver model, where we can start the program as early as 12 months. And the DIR model. DIR is also known as flow time model. It is known as developmental individual difference relationship based model. It was given by Greenspan, and ESDM was given by two lady. I will be covering it later. There are other programs. One is known as Portage program. In Portage program, what happens? The volunteers, they are known as Portage, they give home visit to the parents whose children are suffering from autism spectrum disorder. This was the video. I have asked, huh? Yeah. Early start Denver model was given by Roger and Dawson. Embedded. I wanted to show a few 2-3 minutes video, both of early start Denver model and this one, the flow time. Why it is called flow time? Because it is said that the parents should get down to the level of the children. That is, they should not be like standing here and giving order or giving some directive. They should sit on the carpet or the floor, and they should try to train the children at their developmental level. So what are the formats? One format is one-to-one session with the parent and child. This approach has the advantage that intervention can be tailored to the child's specific needs, enables practice with feedback, and generalization of skills in those sessions can take place whenever needed. Another is the group approach, where the parents of various like children with various types of autism spectrum disorders are given some training in group and then followed up individually. What are the advantage of the group program is that the parents can share their strengths and their weakness, how they have overcome some situations, and it will help in supporting, and it will also be cost effective. Group model improves dysfunctional parenting styles, increasing parents' ability to facilitate the child's development of communication skills and increasing vocabulary. Recently, there are web-based programs also, and partnership models are recommended, and these refer to the parent educator and parent working alongside to develop treatment goals. That is the best partnership model. That means the educator means therapist and the parent, they should work together to development a goal where to take the child and how to progress. Depending on the family's preference, certain degree of liberty is given. It is not very rigid that for every home the program has to be same. Families' values, their preferences, their daily routines, there can be some modification of the program. Some degree of relaxation is possible. More emphasis should be placed on parents practicing new skills, teaching parents to reduce negative communication, that is criticism or sarcastic remarks, demonstrate enthusiasm and let the child take the lead during the play are associated with successful outcomes. Parent educators require important prerequisite skills. Those who will educate or train the parent, they must understand the intervention. They must be able to realize what is actually collaborative teaching style, how to collaborate with the parent. Inviting formal and informal feedback from parents and building rapport by acknowledging parental feelings and listening to parents' concern. It is not like that your child will improve, you keep on doing this. No. You will have to give practical feedback. The parent is training the child and he is facing, the child is not listening to him. Then at that moment, what advice should be given to the parent, that should be known to the educator. It is not some formal written in the book. In a review by Schools et al., program materials found in studies were divided into 3 categories: curriculum, manual, or neither. The authors found that only 10% of the parent education programs reported using a curriculum, and only 43% used some type of structured training manual. The majority of studies did not report using a curriculum. So this was I was talking about the child, the parent and the educator. This is the best model. The WHO has developed caregiver skill training for developmental disorders, because there is a huge gap in delivering mental health care, almost 85%, and which is not possible to be covered by the professionals alone. So we must make some collaboration with the caregiver. Empowerment of caregivers is increasingly recognized as a critical component of intervention. Several systematic reviews of the literature suggest that caregivers are able to learn the skills to deliver psychosocial therapies to their children. Even low-intensity programs lead to improved child outcomes. And there was a WHO commissioned review by Reiko et al. It has found that with training of the caregivers, primary child outcome, secondary child outcome, primary caregiver outcome and secondary caregiver outcome both improve moderately or minimally, at least. It was developed in collaboration with the NGO. Autism Speaks is a practical and culturally adaptable, can be adapted for various cultural settings like low-income countries, high-income countries, with a special focus on families in underserved communities. The program will first train the master trainers, then facilitators, who in turn train parents and other caregivers in the society. Who CST trainers? Master trainers include child psychologists, special education teachers, speech therapists, and developmental pediatricians. Master trainers train facilitators, I have told. Facilitators may be teachers, community leaders, school workers. There are no strict definition or parameter. CST's importance of speaking at the child's development level. If the child's language skills are limited in one or two utterances, then try to extend it. If the child says juice, the parent should say apple juice, orange juice. Try to extend his or her abilities. If the parent and child are building blocks together, the child might say block, so father must say red block. So this way, you must extend whatever strength the child has. It's important for parents and other caregivers to take care of themselves. Incorporating a few minutes wellness yoga or something in the beginning of the session is helpful. Encourage parents and other caregivers to practice these self-care strategies at home. All these self-care strategies recognize that caregivers feel overwhelmed sometimes. Say, Indian Journal of Psychiatry published one paper from Turkey, and there is a very nice work being done by Umid in association with WHO. Thank you.
Thank you all the speaker for beautiful and very informative presentation. Now I have one question to Dhrubajyoti Bhuya. Does the molecule L-carnosine actually work in autism spectrum disorder, in relieving core symptoms of autism spectrum disorder? What is your experience?
See, madam, it is a new molecule, and the results, maybe in a few cases to cases, it has shown improvement, but to comment on its efficacy on the core symptom, we need to wait further because the researches are coming up. But if you ask for the clinical thing or the clinical improvement, then the evidence will be like that of any case report only.
Your experience?
No RCT and nothing.
Now the, yeah.
Thank you very much. It's heartening to see a group forming around autism in Assam across different colleges.
Thank you.
Yeah, that's great to see. I had two questions. One is, what are your opinions on two interventions developed within Indian context called, one is the ComDeal program and the Badhte Kadam developed at AIMS. Secondly, what kind of issues have to be kept in mind in developing evidence base for parent-led interventions? Thanks.
Sir, whatever I can understand, you have asked something regarding some program developed in India. Is efficacy. Sir, whatever I have gone through the material, this CST that is being developed by WHO will be very effective in Indian setting, particularly low-income countries and resource poor. The high rate of psychiatrists and patient that there is a disparity in countries like India. For them, it will be very effective. And already pre-pilot in 2019, it has been done with Umid. Now they are going to training of the master trainers also done. So I think that is a very good intervention program in Indian setting. Specifically, I do not have much knowledge about this thing you asked.
morning. I'm Dr. Vishal Savani from Mumbai. This is regarding the treatment for the target symptoms. When we are talking about aripiprazole and risperidone, there is this conflict as how long, how much and how long. So how do you deal with that?
This is the dilemma that every clinician should face, and the guidelines are not that stringent that how long it has to be continued. So it is based on the individuals and improvement on the patient. But as such, there is no fixed guideline that it has to be given for 2 years, 3 years time. That is not there.
No, because with autism spectrum disorder, you are not targeting cure with these medicines. You are just helping the child to come over the behavioral problems that, so you will monitor behavior and see when the behavior is no more a problem or is manageable, otherwise you will think of tapering the medicine, because the least you give, you help the child best. So that should be the approach. Do you have any more question? So, if there is no more, I have a comment. The sequence that the papers were presented, they are all brilliant papers and presented by very enthusiastic psychiatrists. The sequence that you should go out with in your mind should be involving the family first, caregiver first, giving multimodal treatment next, and trying medicine the last. So just because FDA has given sanction that risperidone and aripiprazole can be used in this group of children, doesn't mean that that should come to your mind first, because with ASD, the multimodal treatment and family involvement, those things are more important. They are the difficult things. That is why clinicians usually love to jump on the drugs, because organizing multimodal treatment is not easy. It's in fact a lifetime job that you will keep building team and learning to help the children. So those things should come to you as first priority, involving the family and providing multimodal treatment. And finally, when you are in trouble and you are not able to manage things well, you'll take help of medicine, because with children, medicine use should be very cautious. Thank you so much. Thanks.
I would like to request our chairpersons to honor our speaker with the certificates, please, ma'am. I would like to call upon stage Dr. O.P. Singh sir to honor our chairpersons, please, sir. Now for today, our second session for the symposium. Our speakers are Dr. Asad B. Biswasa and Dr. Harinder Bains. And I would like to call upon stage our chairperson, Dr. Sagar Lavanya. They are chairing, and the speakers on the topic for multidisciplinary management of the neurodevelopmental disorder, autism, and ADHD, sir. Please welcome, sir.
Namaskar, very good morning. It's a delight to be in this wonderful conference, very well organized. Before I come to the symposium, today's symposium is in the line of earlier symposium that we had about autism and neurodevelopmental disorders. When we see child psychiatry is still in a nascent stage in our country. Very few years back only, we have started super specialization in child psychiatry and only at a limited centers. We all know we have our own challenges in child psychiatry, especially as far as I am concerned. I always think that it is very difficult to explain the parents and guardians that how the non-pharmacological management is important for these diseases. Similarly, it is also very difficult to convince them about the long-term therapy of these patients. We have some differences in terms of management because our two speakers are from developed country, from UK, and we are very happy because they are both from Indian origin. So the symposium, what we will have, first the speakers will present, half an hour for each speaker, 20 minutes to half an hour, and thereafter we can take the questions. With this, I invite Dr. Vishwas for his topic.
Good morning, everyone. Thank you, Dr. Lavanya, for the kind introduction. So my name is Asid Biswas. I work as a consultant psychiatrist at Leicester. It's a nice leafy county, Leicestershire, and you might have heard of some very famous people from Leicestershire. The Attenboroughs, David Attenborough, the Blue Planet environmentalist, who talks a lot about climate change these days. Of course, Richard Attenborough. You might have heard of Sir Alex Jeffreys, who was at Leicester University. He was the founder of genetic fingerprinting. So this session is the British Indian Psychiatric Association slot. Our president, Dr. Mudalkar, is in the audience. So, would you speak a bit about BIPA in the end? Yes, and our Dean of the Royal College of Psychiatrists, Dr. Lovett, is in the audience. Nice to see. So Dr. Bains and myself will be talking about multidisciplinary management of neurodevelopmental disorders. We'll be focusing on ADHD, which I'm going to talk about, and Dr. Bains will speak on autism and autism spectrum disorders. Okay, this is a standard disclosure slide. I have no conflict of interest because I'm not going to name any specific brand names when I am doing this lecture. I wish to acknowledge some of my colleagues, Dr. Brotherton, Dr. Arif, and Dr. Tom Byrne, whose name is not there, who have kindly given the permission to use some of the slides in this presentation. Okay, I was expecting about 100 people, but not quite so this early in the morning after last night's banquet. So Are there any child psychiatrists in the audience? Right? Please show. So one person at least, and most of you work with adults. So just a question for the adult, general adult psychiatrist. Do you work in a multidisciplinary team where you work? Yes? So one or two show of hands. And I was looking at the program. There was one other talk about multidisciplinary teams in the whole of the 4-day conference. So perhaps this talk is timely. Okay, you might have heard of the National Institute of Health and Care Excellence in the UK. So this is a body which produces guidelines, health technology assessments for use in the UK. It publishes standards, and services are they are measured against these standards. So what does NICE say about multidisciplinary working in ADHD? Somehow this slide got a bit cut off. Can anybody do anything about it? Anyway, so mental health trusts and children's trusts that provide mental health, child development services should form multidisciplinary specialist ADHD teams and/or clinics for children and young people, and separate teams or clinics for adults. And these teams and clinics should have expertise in the diagnosis and management of ADHD. Now, this is something which I might point out. When they say should, that means it's a good idea, people should do it. And if they say must, it's essential, it has to be done. So interestingly, it doesn't say must there. I think it should. So here we have the overview of the ADHD care pathway. So there is a person with suspected ADHD. Number 2 is about commissioners. So we have commissioners who commission mental health services. They provide the money basically to the providers, which are NHS trusts, National Health Service trusts. So it's the job of the commissioners and the providers to plan services, specialist services for ADHD. So who are the people who recognize or do the screening for a referral to an ADHD specialist service? So it's the primary care, the general practitioners. So every citizen in the UK has a named general practitioner who the patient goes to, and they make a referral to specialist services. Specialist ADHD services are charged with making a proper diagnosis. And then somebody was talking about psychoeducation in the earlier talk. So provision of information, support for the patient, management. Now training is very important. So at all levels in psychiatric training, ADHD is an important part of the curriculum. So for basic training or core training as they call it now, or higher specialist training. And an important area is transition from children's services to adult services. Often there is a gap and the handover needs to happen properly so there is continuity of care. So what is the role of a specialist multidisciplinary team in an ADHD service? So these are the 4, I'm sorry, the last one is getting cut off. First one, obviously, is diagnosis, treatment, and consultation services for people with ADHD who have complex needs or where general psychiatric services are in doubt about the diagnosis and or management of ADHD. So I'll tell you what happens in Leicester. The general adult psychiatrists refer anybody they suspect might have ADHD to the ADHD specialist service. So I work as an intellectual disability psychiatrist mainly, but do 2 sessions in the adult ADHD service. And the ADHD service deals only with ADHD, nothing else. And we have a MDT. It's not a full MDT, but I'll talk about that later. The second point is to put in place systems of communication and protocols for information sharing among pediatric, child and adolescent, forensic, and adult mental health services for people with ADHD. As you may be aware, people with ADHD end up in the criminal justice system. It's usually not major crimes. It's something they did impulsively, because they were angry, they punched somebody. So like, actual bodily harm, assaults, so minor thefts. So those are the kind of things they get charged with, usually not the more serious end. It's as a result of their impulsive behavior without thinking what they're doing. Produce local protocols for shared care arrangements with primary care providers. Now this is important because once the diagnosis is made, the patient's management plan has been set out, the patient has shown significant improvement, and the patient is stabilized, then there is no further need to see that patient in the specialist ADHD clinic that regularly. Maybe an annual review would suffice. So the shared care agreement is done with the general practitioner who takes over the responsibility for prescriptions and monitoring for side effects, blood tests, ECGs, etc. The fourth one is ensure age-appropriate psychological services are available for children as well as adults. Okay, so what is the role of the psychiatrist? I mean, this is teaching granny to suck eggs. I'll just, for the sake of completion, I put it there. So as you do, you take a parent-carer interview. A full developmental history as part of that is important. Interviewing the child or adult. And we use questionnaires, which are very important. So the one commonly used for adults is called the DIVA, or the Diagnostic Interview for ADHD in Adults, the DIVA 2, version 2. And for people with intellectual disability, there is a DIVA ID 5. A psychological educational assessment, a history and clinical examination, and physical, psychiatric, and psychological assessments. Now, these are some of the other rating scales, which I'm sure you use in your own practice. For children, we use the QB testing, which is the quantitative behavior technology, which is on a computer. There is a motion tracking analysis with a uniquely designed continuous performance tracking tool, which at the end of it gives a diagnosis. So our child services use that quite a lot. So these are the drugs that are used for ADHD. But what does NICE say about them? So essentially there are 3 stimulants. Atomoxetine is used. We used to use imipramine before. And guanfacine is the new kid on the block. So pharmacological management. NICE says, National Institute of Health and Care Excellence, the 2018 update, that psychostimulants, methylphenidate or lisdexamfetamine as the first line of drug treatment for the core symptoms of ADHD. And the good news is about 70% of patients respond to a varying degree. Now, in all of psychiatry, ADHD is one condition where the core symptoms of the condition respond that well to medication. It's important to bear that in mind. It's even better than response for hypertension. So say if I start somebody on methylphenidate. Now methylphenidate is available as immediate release or extended release. A trial of 6 weeks at an adequate dose. And if the patient tolerates it, well then good. And if you see benefit, well and good. But if you don't see the benefit, then I would try lisdexamfetamine. And if for some reason they don't tolerate lisdexamfetamine, dexamfetamine. In America, they tend to use Adderall. In UK, we don't use Adderall. The second line is atomoxetine. And guanfacine, the European Medicines Agency has approved of its use, which mimics postsynaptic stimulation of alpha-2 receptors in the prefrontal cortex. So the ADHD pathology is mostly in the prefrontal cortex, executive functioning, organization, planning. I'm not going to so much detail on that one because then I'll deviate far from my topic. Okay, so these are the general guidance when prescribing psychostimulants. we commence with the smallest possible dose and titrate to 2 or 3 times daily, or in the case of extended release preparation, once in a day in the morning. Most of the extended release preparations of methylphenidate and lisdexamfetamine, they stay in the system for 12 hours and wash out, and every morning, next morning is a fresh day. So addiction potential, because of the formulation, is not practically there. It is important to do baseline tests, including blood pressure and pulse, because the ADHD medication increases the blood pressure and pulse by 5% and even more. In children, height is important because stimulants can affect their epiphyseal bone growth and hence their height. And other baseline tests are kidney function tests and liver function tests, and an ECG. For example, if they have a long QT syndrome, you want to know that before you start somebody on methylphenidate. And NICE has introduced that the specialist ADHD psychiatrist needs to auscultate for murmurs in the 2018 update. Okay, so monitoring should be carried out at the discretion of the supervising clinician. Combined drug treatment may be indicated in certain cases, especially where comorbidity is a feature, but should be supervised by specialists and expertise in the field, drug-drug interactions. In people with intellectual disability, we adhere to the Mental Capacity Act. So if people lack capacity, interests, a best interest decision is taken by everyone who has a stake in the welfare and the healthcare of that particular individual. So non-pharmacological management. There is actually limited evidence for the effectiveness of psychosocial interventions in managing the core symptoms of ADHD. Nonetheless, all behavioral symptoms presented by a person must be assessed. Now, this is quite important. Comorbidities can be treated with psychosocial intervention. So when as a psychiatrist, do we refer a person to a multidisciplinary team? So no two people with ADHD are the same. I mean, that's stating the obvious. Now, which is important. So my question would be, how much time on an average do you as a psychiatrist have available to treat a person with ADHD in your clinic? Half an hour, 1 hour, once a month? So it's not possible for the psychiatrist with so much limited time to provide interventions which many other professionals allied to medicine are good at and trained in and have the time. So I'll come to what the multidisciplinary team can do for the patient. So I need to know what I'm expecting from the referral I'm making to the multidisciplinary team, isn't it? So I have referred somebody to a psychologist, but what do I want the psychologist to do for my patient? I need to know that. Now, resource limitations are present in most services. So hence optimum use of services are important, development of minimum standards, establishing, so that needs a lot of leadership from the psychiatrist, liaising with other agencies to get the funding in, and continually improving services. Okay, so it is important for the psychiatrist to understand the life of the person, of their patient with ADHD, and what impairments do they face on a day-to-day basis. So this is an acronym I use, FOCUS. So one of the big areas people have problems, and adults say, is with their attention and focusing on the task at hand. So hence they never complete tasks. They end up in trouble because of that, because deadlines are missed, the boss is unhappy, children in school don't hand in homework because they've only partly done it. Because of the prefrontal cortex issues, organization and planning are important, so they procrastinate, said, oh, I'll do this project at some stage. But if we know you need to plan a project, break it into bits, and start and complete each part of the project. People with ADHD are not able to do that. There needs to be cognitive flexibility. People with ADHD have impulsiveness, which they can't control, and emotional dysregulation. And I'll just go over these issues. So for example, so they might say to you, I struggle to finish work or school tasks. It's important to listen. I would make a note of that, because that's the person, that's the reason why the person has come to you for help. Like when I said no to people with ADHD are the same, so they know what issues they have, and it's important to record that, and then do something about it with the help of the multidisciplinary team. So they might say, my attention wanders easily when I'm working or studying. So that might be due to own thoughts. They think of something and then go up and do something, or some activities or noises they get distracted by. So distraction is an important feature of ADHD. So the impairments are their academic achievements are poor relative to their IQ. They don't achieve their potential. Sad. And with proper help, they could have. So career progression at work is impaired. They keep changing jobs. Either get fired or sacked, or they have frequent arguments with their bosses. So organization and planning. So they might say, I often lose and forget important items I need for work or tasks, like files, folders, notes, even laptop tools. So they come to work without their tools. How good is that? So they have problems because of lack of organization and procrastination in starting projects. So like I mentioned before, that leads to incomplete schoolwork assignments and missed deadlines. They're always late. And because they're always late, they try to get there 1 hour early. Have you noticed that? Many of your ADHD patients will turn up 1 hour early because you have given them a timed appointment. Now, I mentioned about scaffolding. So children or even adults will have another person around them who minds their structure for the day, for the week, appointments, etc. And that's how they get by. But many people don't have that. So they might say, oh, yes, I used to always get to school on time. And then when you explore further, they say, yeah, my mom used to make sure I'm ready on time. But if mom wasn't there, that person wouldn't be ready. So that's the scaffolding. Cognitive flexibility. So they might come and say, I struggle to keep track of several things at once in my mind. That's a typical ADHD patient. It's hard for me to recognize alternate options in most situations. So they don't see several options and pick and choose one. So my option is the only option, and anybody else says anything else, then that's just wrong. And in the process, what happens is, because of so many failures, they lose their confidence, even in tasks that the person is good at. And that results in poor school or work performance. They're not able to reflect on their own thoughts or see another person's perspective or learn from their mistakes. No doubt they have an angry spouse at home, disharmonious relationships, family, and the friends, oh, he's coming that way, let's walk the other way, So it's not nice for the person with ADHD. Unstable emotional regulation. So this is quite typical. They might say, I get irritated very easily, I'm easily angered, and have a short fuse. And I find it difficult to let go of difficult emotions, like anger, frustration, sadness. Very impatient people, very fidgety, because they're thinking of something else, and they've got bored by the time you have started discussing something with them. Very difficult to engage. So they end up with strained relationships, changing jobs frequently, emotions too intense, which hinders their performance, colors their perception, and causes a lot of distraction. Impulse control problems. They might say, I tend to answer before the person finishes asking the question. I say things before thinking through, annoying people, and wish I could take them back. And this happens again and again. They feel sorry by what they said and why they hurt somebody else they didn't mean to. Fidgety, can't be seated for long. So about 4 out of 100 people, 100 adults have ADHD. So I'm sure if there are 100 people here, there are 4 of us who have ADHD. I just said that to wake you up. So what are the impairments? The ability to behave appropriately is central to succeed. We all know that. progress, career progress-wise, or even socially. Because impulsive behavior is seen as irrational by others. You can't trust an impulsive person, can you? Person is not seen as reliable. And the person doesn't finish things. So they do struggle with the consequences of impulsive behaviors, the decisions they make, the choices they make throughout their life. And that can change with appropriate help from a multidisciplinary team. So, for example, we can ask the ADHD nurse to do many of these things listed there. Okay, so the role of the GP would be once the person with ADHD has stabilized to hand over their care for monitoring medication, height, weight, BP, prescriptions, monitoring side effects. If somebody has drug abuse issues, appropriate referral to the drug abuse de-addiction clinic. So this is the kind of overall treatment of ADHD. Okay, so what do I expect from the multidisciplinary team? So as a psychiatrist, we know our role, making a diagnosis, and it has to be done taking into consideration the history provided by a carer or a relative, or in the case of a child, their parents. School reports, because school reports pick up things like, has too much energy, always on the go, doesn't pay attention, could do better if he could concentrate. So these are kind of pointers that this person had problems right from childhood. So in our clinic, we do ask for school reports. Then using appropriate questionnaires. So for adults, we use the diagnostic interview for ADHD in adults, called the DIVA version 2. Now this is available online. It was developed by two Dutch psychologists. They call their foundation the DIVA Foundation. So if you Google DIVA Foundation, it will come up. What they have done is they have taken the criteria from DSM-5. It used to be DSM-4 before, but DSM-5. And there are 3 parts in this DIVA questionnaire. Part 1 looks at the 9 clusters of attention deficit symptoms. Part 2 looks at the 9 clusters of hyperactivity, impulsivity symptoms. 6 of them are hyperactivity, 3 of them are impulsivity symptoms. And part 3 looks at impairments in 5 areas. So in at least 2 of the areas, the person would have impairments due to their ADHD symptoms. So these areas are the school, work, performance, family relationships, social contacts, how they maintain their leisure activities, and also, confidence, a negative view of themselves. So using the questionnaire is very important. Now in the questionnaire, each of the cluster of symptoms, there is a statement made in the form of a question. And there are examples laid out in childhood, in adulthood. In fact, some of the symptoms that I had listed earlier are from the questionnaire. So when you state the example, the person may identify, yeah, I am like that, that's me. Now, some people make a spot diagnosis. One of my colleagues says, the first time they see a person and they are walking towards the clinic room, the person with ADHD always walks in front of them. They don't know where they're going, but I know, you don't make a diagnosis just on the basis of that. Role of the ADHD specialist nurse. So in Leicester, what we have is 2 whole-time equivalent psychiatrists. So we do the diagnosis, the medication, the monitoring, and overall management till the patient is stabilized. Then we have the ADHD specialist nurse. We have got 3 of them in Leicester, which is quite good. Happy to say Nottinghamshire is developing services. They have 1 ADHD specialist nurse. Some counties don't have that as yet. So we have had the ADHD service in Leicester for more than 12 years now. Initially, it started off because of the endeavor of Dr. Arif, who had an interest in ADHD. And people saw value in it, and the commissioners then provided the funding to expand the services. Number 3, psychologists. So many people with ADHD have anxiety problems over and above what is due to the ADHD, and they would need cognitive behavior therapy. We don't have a psychologist as yet in Leicester dedicated for people with ADHD. So resource issues are everywhere. Nobody has unlimited pots of money. ADHD coach. We don't have one in Leicester, but I think an ADHD coach would be very useful because the person then walks with the person with ADHD, provides social skill training. Little things, situations that the person encounters every day. For example, the person with ADHD sat at a big, board meeting, and something is being discussed about progressing some aspect of business of the company, and he comes with a real bright idea. And what do you think the person with ADHD will do? He'll blurt it out immediately, isn't it? And then other people are still on a different page, haven't reached his stage as yet. So they think, what is this guy saying? Now, it could be if the person wrote it down, his idea, and elaborated on it in his own mind, during the discussion, it might lead to a point at which stage, if he said it, people will think, this guy is a genius, that's what we want to do. So the ADHD coach could help the person in his own sphere of work, life, home, to help not behave impulsively. Now, like I said before, this would be in addition to medication, because medication does have a very significant effect on the core symptoms of ADHD. Social services could help with employment support, benefits, and GP I mentioned about. Now, we rely a lot on our cardiology colleagues. We have got a very good cardiology team in Leicester, because once in a while we'll have an ECG, it's a baseline ECG with issues. So bundle branch blocks, ectopics, and even more serious issues. People with hypertension. Our neurology colleagues help with people having other disorders like tic disorder. Sleep disorders, people with ADHD have many sleep issues. So a percentage of them respond, and the sleep becomes better if they are less anxious at bedtime, and they fall off to sleep. But there are others who have other sleep disorders in addition. And because in Leicester, in the ADHD clinic, as a psychiatrist, I only treat ADHD. They have another psychiatrist who treats their depression or bipolar or anything else they have. Okay, I think that's where I'll end, well within time. So what we decided is about Dr. Benz and myself will take questions at the very end. Okay, thank you.
Thank you, Dr. Vishwas, for this excellent talk. The next speaker is Dr. Harinder Singh Benz. He has been my senior in medical college days. He has done his undergraduation from SN Medical College, Agra, and then he went to England and did his MRC Psych and FRC Psych, and recently he has also done LLM, right? And he's working in Astley Healthcare as a lead consultant in South London. Apart from his educational qualification and excellence, in our medical school days, I must say this, that he was known for his flamboyant nature. 20 years back, can you imagine an imported motorcycle and a car in the hostel? He used to have that. And I remember all the good and bad things that we did in his car. With this, I invite Dr. Benz, please.
Next previous and point.
That's the pointer. Okay. Well, thank you, Dr. Lavanya, for that generous, kind introduction. I'm glad you didn't give away too many things, but there you go. So, and can I say thank you to everyone who's here? Sorry, I've just jumped a slide there. Thanks for your commitment to coming here this morning and listening to us. Can I also say thank you to Kate and Santosh, who are here, braving sleep deprivation, I think, to come and be with us. And it's also good to be here and see some familiar faces in the audience. So it's it's very nice to be here. What I'll be doing is a bit of a whistle-stop tour of ASD management, how we do that as a multidisciplinary team. I work in a neurodevelopmental service. I look after an ASD service. And so I'll be talking about my experience of how we set up the service and how we run the service. So let's get the buttons correct. So I'm not going to talk about autism. What is autism? People know what autism is. We know about the difficulties with social interaction, particularly reciprocal social interaction people have, difficulties with abstract thinking, imagination, issues with communication, verbal and non-verbal communication, and of course repetitive and restricted behaviors. Now, I work in a service for adults. I'm just curious, are there any people here working with adults with autism? Yeah, Kate works with autism. So, sorry, where do you work? Yeah. So Kate works in Plymouth. The gentleman behind Kate, where do you work? Okay, so it's interesting to have a few people who work with adults with autism. Just talking about the general setup of ASD services in the UK. There's community-based services which are usually attached to community mental health and learning disability teams. And then there are inpatient services, which broadly can be divided into secure and non-secure services. The community services, interestingly, have mainly been diagnostic services for a long time, saying that there are now services coming up which are providing more management for people with ASD. It's always easier to have a diagnostic service, but it's more resource intensive to have a service to manage people with ASD because it's a long-term condition. Talking about inpatient services, so we have secure and non-secure services. I look after a secure service, and the difference between the non-secure and secure services is generally the pathway. The non-secure services are generally short-term inpatient care services. They tend to manage people in the community who have difficulties and need short-term inpatient care. They're generally commissioned locally by CCGs. And when I say CCGs, these are local commissioning groups versus the secure services, which are generally nationally commissioned by NHS England directly. The secure services, on the other hand, are more sort of attached to the criminal justice system. So you get people from prison, you get people from courts. They tend to be longer-term patients. They tend to have more comorbidity of mental illness or personality disorder. And the services are based on security specifications and specifications set by the secure model. But interestingly, we don't really have a national service specification as yet for these kind of services for autism in particular. So that's a picture of where I work. It's a nice sunny day in England, which is very unusual. So we had to wait a few days to get that picture because normally it's quite cloudy and it's raining. So that's our ASD service. We opened the service last year. It's the only service in the south of England, the only secure service in the south of England, which is set up in collaboration with the commissioners. And what that gives us is better quality of care because commissioners pay for the service. Commissioners also monitor the service. There are also people who discharge from the service. So we work collaboratively with them and try and get people through our inpatient pathway as quickly as possible. Just generally, before I go on to the multidisciplinary management structure that we have, Asit mentioned the National Institute of Clinical Excellence, NICE. So there's guidance from NICE about management of ASD. And it was actually quite interesting to hear the presentation before us and hear about the way things are working in India. And also a comment from the chairperson that we should be focusing on psychosocial interventions, supporting families, and actually not focusing just on using medication. So that's the principle behind the NICE guidance as well. So just to sort of a quick sort of overview of what the NICE guidance says. There's a strong focus on working with families, and it's about providing information, sharing information with families, and that is a big part of management because we find families are sometimes not sure about what's going on. Interestingly, even a lot of people who come to us as adults and they get diagnosed late in life. And so it's very important to seek the support of families. They're the people who understand the person the best. So working with them in partnership and also making sure that we're not withdrawing services on the assumption that there is family support. So that's a big part of how we work. And then in terms of the interventions, as I mentioned earlier, are psychosocial, taking into consideration the nature and severity of the condition. Any previous intervention response is quite helpful in deciding what intervention we use. Comorbidity is a big part of the presentation, and comorbidities, obviously, if we get things like mental illness, then in a way that is the easier part of managing autism. But obviously they have a big effect on the presentation of the person. And also personal and social factors, managing crisis for people is a part of our care pathway. And based on the NICE guidance, our care pathway extends into the community. We work with community services to discharge people. We have joint working for a period of time so people can settle into the community. And then in terms of the biomedical interventions that NICE suggests, medication is mentioned in the NICE guidance, but interestingly, there's a long list of medication NICE recommends we should not use, and that includes anticonvulsants, it includes oxytocin, was mentioned earlier, the anticholinesterase inhibitors. They also recommend that we don't use naltrexone, and they generally recommend not to use antipsychotics just for the treatment of autism. Obviously, antipsychotics are used for treatment of arousal and autistic anxiety. And like I mentioned, treating coexisting mental disorders will obviously involve using medication. And then just a quick flow chart about managing what we call challenging behavior or behaviors that challenge. Again, a very psychosocial, environmental model is what we tend to use, looking at triggers, environmental triggers, changes in people's lives. So it's very important to involve families and carers in understanding that. And then pharmacological intervention does figure in there, but as you see, it kind of comes down, it's kind of lower in the hierarchy. And it's very important to monitor interventions, and that is where the multidisciplinary setup that kind of surrounds or scaffolds the patient is quite important. So I'm using the team that I work with as an example of a multidisciplinary team. So we have medical input. I work as a consultant for the team. I'm a 0.6 whole-time equivalent, so it's just over half of my working week is my clinical work. I have an associate specialist who is also sort of half-time. What you will find is, if I can get this pointer working, is the big therapies team that we have there. So the model is very much therapy-driven. We have a full-time psychologist. We have an assistant psychologist. We have half an art therapist who works 2 to 3 days a week. We have a drama therapist. We have a positive behavioral support therapist or practitioner who works with us and is very pivotal in designing the behavioral program. We have a full-time occupational therapist and an assistant, and we also have a social worker. And we have quite a robust nursing team. So the medical role is mainly to provide clinical leadership to the team and also to give direction to the team. Our service is a new service, so a lot of work has gone into giving the team a model and giving it a bit of direction, working collaboratively with external stakeholders, including commissioners and community services. Obviously, medication is monitored by the medical team, by myself and my associate specialist. I also have a mental health role, mental health act role, so I'm the responsible clinician legally under the Mental Health Act for our detained patients. And a very important part of our role is a physical health care side, which can sometimes be neglected if we're not careful, and maintaining liaison with the general practitioners, but also with hospitals. Nursing staff provide 24-hour supervision. They are a specialist team who have had training in looking after people with autism. They look after various aspects of behavioral management, self-care, monitoring, administering medication. We have done away with things like patients coming to the hatch, as we used to call it at the nursing station, and coming for their medication because we thought it was quite demeaning. So we provide a very person-centered approach where every patient has an individual plan of how they like their medication to be administered, including encouraging self-medication where they can. The nursing staff are very important in terms of managing activities and leave, particularly for detained patients, getting them out of the hospital setting and taking them. A lot of people just enjoy shopping. One of my patients enjoys going to museums. One of them enjoys trains. He's got an obsession with trains, so he goes to the train station 3 or 4 times a week. When I'm traveling by train, he can almost give me a timetable of which train is going where, which is quite handy. And generally, nursing staff are the ones who are with patients most of the time, so they are coordinating the care. Our psychologist team, as I said, is quite an extensive team. The psychologists offer the offence-specific work for people coming from the criminal justice system, and that might be the violence reduction program or the sexual offender treatment program. They offer an adapted program depending on people's needs and generally on a one-to-one basis. They also help with the formal risk assessments that we have to produce for not just the day-to-day management of patients, but also for the future management in the community. The group work is mainly done by the art and drama therapists, and again, that's a very important part of it, engaging people in our therapeutic work, because it's a very indirect approach which a lot of patients find very helpful in just getting them into that program of any psychological work, which otherwise on a one-to-one basis can be quite daunting. They also help staff with formulations and helping staff understand patients. I mean, we are very aware that our patient group is quite a heterogeneous group, and every patient we have with autism is very different. So having a formulation individually for each person is quite important. And we have a speech and language therapist, which we are quite lucky with because it's quite difficult to find speech and language therapists in the UK. And I'm sure, Kate, that is probably your experience as well. It took us quite a while to find one, but she is brilliant, and she helps with all the communication work that we do. So her role is pivotal in actually the team working with the patient. But also, I mean, we're talking here about using IT in psychiatry. They use simple apps like talking mats just to prepare people for things like their review meetings. I've got a quick video here. Can I play the video from the link? Would that be possible? Let me see if I... Sorry, can we play a video from that hyperlink there? That hyperlink there, would that work?
This hyperlink doesn't work. Just check it. Is it a video?
Yes, yeah.
It's an online video?
Yeah.
So it's connecting.
Right, so whilst we are connecting, there we go. So this is a brief video of how the app is used to help people work with the team. I think it's early in the morning, the connection's struggling as well.
First of all, by asking you about how you're feeling about school.
I find school quite good. I've got a lot of help. School in general just got quite easier as the year goes on. I've got my exams this year and feel quite confident with them.
Okay, so where would you put that?
I'll put it in the good book.
Yeah, so you're feeling happy about that. Okay. James, so how do you feel about your review meetings?
A wee bit in the middle of
Okay.
not the greatest things
I know.
that I like.
Okay. Where would you put it, do you think?
In the middle.
So, how do you feel at your review meetings? Can you tell me a little bit about that?
A bit nervous as well because I've got a lot of teachers saying that I do good work, I just need to concentrate more, sort of shouting at things.
Okay. So do you find it a little nerve-wracking being at the review meeting? Yeah. Okay. Okay, this one's asking you about how you feel generally about how accepted you feel for the person that you are within the school community, but also within your wider community.
Yeah, a lot of people have accepted me what I do. Being in the community, everybody knows me as the bell ringer or something.
Okay.
In school, people know me as that as well.
Okay.
I'm quite happy about that.
Okay. You like being known as the bell ringer?
Right, so let's go back to the presentation. Right, so that was talking mats being used in schools. Again, it's quite a visual tool which works well for people with autism, and we're using that within our service as well. And then another important part of our team is a social worker who works with families. They maintain the liaison with families, the feedback to families. We've started this process of giving feedback on a weekly basis to some families. And the social worker is sort of central in that role. Also, people have other issues like financial issues which need to be sorted out sometimes when they come to inpatient services, and at some point they will be discharged, so it's making sure that they get all the benefits that they're entitled to. When there's forensic issues about victim support and working with, MAPA stands for what we have. We have a multi-agency public protection agency, which includes healthcare workers and police and people from the criminal justice system. So the social worker is our link to MAPA and making sure that we have safe discharges, and also when people go out on leave, we involve MAPA in that process. And they have a statutory Mental Health Act role as well, particularly around informing the legal system about how we are working with external stakeholders to discharge people. Occupational therapists are a big part of the rehabilitation work that we do. They look after not just the day-to-day activities on the ward, but they also look after the vocational training that we provide in liaison with external colleges. A lot of people come to us and want to get qualifications, so they coordinate that. Leisure activities, as I mentioned earlier, they do risk assessments and safety assessments around people stepping out, going out of the hospital, doing community assessments, things like, can they use the bus safely? Can they use the train safely? Are they safe with understanding risks, road safety, things like that? And they also run groups on the wards. So some of our patients with autism have understandably quite stereotyped interests, and they like certain activities, and one patient in particular likes activities on the ward, so there is a sort of bespoke program for that particular patient. And in the hospital, of course, we have other support staff. We have an advocacy service, which are independent advocates who speak up for patients. So they will meet up with patients, and if there's any concerns, they will speak up for patients. We also have solicitors who are not a part of our team. They're external people who are independent, who represent people who are detained under the Mental Health Act. As I mentioned earlier, we have NHS case managers. So these are people who buy the service and also monitor the service. They actually come onto our service on a regular basis. The requirement is quite intense for them now. They're required to review all their patients, and sometimes they have patients all across the country. They're required to review them on a monthly basis now. And then within the community services, we have people we call the gatekeepers. So these are people, consultants generally working in the community, who decide where the person should go in terms of the level of security. And of course, our security staff in the hospital are important, and to keep the place clean, we need our housekeeping staff as well. I forgot our catering staff, so we have a big kitchen as well as a part of the hospital. So I think I will end there. We've had about a year's experience in this new service. We've had good outcomes in terms of we have discharged 3 people in a year, and these were people who have been in inpatient care for many years, including one who'd been in inpatient care for 7 years. And I think it's come through multidisciplinary working with them, understanding what their needs are, but also making sure we don't work in isolation, that we are working with people outside the hospital, in the community, people who are buying the service, and with families. So I shall stop there, and thank you for patiently listening to me.
Thank you, Dr. Pence. Before I announce this session and for any question and answer round, I have my own questions. And this is not specific to the speakers. We have Dr. Shantos, BIPA President, and anyone can answer that. Because what we as a psychiatrist always see, almost every week we see autistic patients and patients with ADHD. So pharmacological treatment is okay, but once we think of multidisciplinary sort of treatment where psychologists are involved, social worker are involved, an art therapist was also there. We do not have such luxury in India, and I'm sure even in UK you must be having problems by getting all these resources. So is there any telepsychiatry or something like that where you can teams sit at a same place and provide their services to distant area? Do you have, what is the role of telepsychiatry in this?
I'll talk from an ASD point of view. I think there is a lot of scope for developing telepsychiatry here. We have started using things like Skype now. I think a lot of diagnostic clinics in the community are beginning to use that. It is challenging with assessing people with ASD because you need to be with the person to get a feel of a lot of the sort of non-verbal stuff that you observe. So if you're doing a diagnostic instrument, say ADOS, it is actually quite difficult to do it if you're not sort of with the person. But saying that, in terms of providing liaison, in terms of providing consultation for follow-up of people, I think certainly there is scope for telepsychiatry, and that way you can reach out to bigger services, a larger amount of services. Also, I mean, in the UK, we have diminishing resources as well in healthcare. We are expected to provide more for less, and hence thinking innovatively is the way forward. I think probably for ADHD you have similar.
For ADHD, I think the theme of the IPS conference is the digital psychiatry is the psychiatry of the future. In ADHD, there are apps available which mainly help people with time management and timeouts to take regular breaks. There are anxiety apps. But having said that, we don't know the evidence base and how effective they are. So I suppose there will come a time when some of these also-rans will drop off, and the more robust apps people will keep using, and at a certain point there will be research done on how effective they are. I think there will be. There is a future for apps for people with ADHD.
That makes sense. We are already overshooting the time. Can we take a couple of questions, please, quickly? Sir.
I am Dr. Mohammad Mustafa from Bangladesh. I am a consultant in a hospital there. My question to Dr. Biswas, what precaution can we take so that patient taking methylphenidate does not become addict or drug dependent?
Sorry, the last bit I didn't understand. What precaution do you take with methylphenidate and?
And the patient does not get addicted to the methylphenidate or dependent.
Sorry, are you treating somebody with depression and ADHD?
No. You have told that some patient with...
Oh, I see. Okay, yeah, I understand your question. Now, the methylphenidate formulation is available as immediate release or extended release. Now, immediate release preparations, their action stays for 4 hours, whereas the extended release preparations, there are several companies which make it, but I'm not allowed to say company names. So their action is there, they stay in the system for 12 hours, and then they wash out. So there isn't a problem with dependence. Now, if somebody is choosing, say, person who is addicted to stimulants, speed, for example, wants to take, say, amphetamine or lisdex amphetamine, for example, and use it for a high, the formulation is such and the way it works is such they won't get a buzz, even if they tried. So hence, both psychological and physical dependence does not happen. Yes, so if you use, because it gets washed out, the next day is a fresh day. So say in children, we do drug holidays. So if they basically go on holiday, they don't seem to need the methylphenidate. At weekends, when there is no school, they don't use the methylphenidate. They don't get withdrawal symptoms. So there is no dependence. They don't get tolerance to the dose of the methylphenidate, hence no dependence. So from a pharmacological point of view, people don't get dependent on the prescription methylphenidate.
Sure.
Good morning. I'm Dr. Lakshman from Bangalore.
Sorry, sir, this will be the last question, sir.
Sorry?
This will be the last question. I'm sorry, you can continue after the session. Speakers will be there.
Do you want me to speak or not?
Yeah, yes.
That's fine. I'm a little bit confused. Yeah. I'm Dr. Lakshman from Bangalore. The questions are to the speaker himself. There is a question and there is also a comment. The question is that you have rehabilitated 3 patients in the last year, I think you said, correct? 3 patients. What was the level of rehabilitation? Because the object is mainstream reintegration to some extent.
Yes, so 3 patients have been discharged into the community. So they have, in a way, you could say they've completed the rehabilitation. But rehabilitation is obviously an ongoing process of the inpatient care pathway.
Yeah.
So as I said, the work that we do within our therapies team is continuously working on the rehabilitation pathway.
Okay. The second thing is the nature of a comment. Recently, in the last 5 to 10 years, there have been a large number of psychiatrists who have returned from the UK to Bangalore. And I was very intrigued by your use of the word responsible clinician. In the UK of the 80s, there was a definite structure. There was a consultant, there was a senior registrar, there was a registrar, there was a senior house officer, and there was an intern. And we all knew our responsibilities. I've heard remarks that the word responsible is a nice word because if things go well, the multidisciplinary team takes the credit. If things go badly, the doctor gets hit.
I think, first of all, the term responsible clinician is a legal term for the consultant who is actually in charge under the Mental Health Act. So there is a clinician who has to take legal responsibility. So it's a term under the Mental Health Act. I've actually been quite lucky, I think. I've been given a lot of credit for the work that my team have done. So I need to make sure I share a bit with them. Yeah, I think I should visit Bangalore as well. I, might take your invitation to see what happens in Bangalore. Thanks for your question and comments.
I'm sorry, I've already closed the session. Dr. Santosh has raised, he's a BIPA president. I'm sorry, sir. Because the next session will get delayed. He will be here. You can ask him. He will be here till evening. So with this, I thank both the speakers and patients listening from the audience. We were not expecting this. Initially, we were very less, and now it's a lot of audience here. Thank you very much, and I will close the session here. Thank you.
I would like to request our chairpersons to honor our speakers, invited speakers. I would like to call upon stage Dr. Rajesh Nagpal to honor our chairperson, Dr. Sagar Lavanya. So. So for the day, our third session for the plenary theme symposium by Dr. Rajesh Nagpal and our honorable chairperson, Dr. P.K. Dalal. So please come on the stage. So.
Good morning, everybody. And now we are going to have our first plenary session of the day, and that is the theme symposium. The theme for this conference is Smart Psychiatry in Digital Era. And we all know that how, as has been said, that different kinds of technology is being used in the management of psychiatric illnesses, maybe even training, assessment. And there are supposed to be two speakers, but Professor Madhukar Trivedi from US could not make it. So Dr. Rajesh Nagpal is here, the other speaker, and he'll do the justice for the topic. Dr. Rajesh Nagpal is a practicing psychiatrist at Delhi, and he is a PGI postgraduate. So without wasting time, may I invite Dr. Rajesh Nagpal to continue with his presentation. Thank you.
कैसा कर रहे हो कर रहे ऑनलाइन तुम आप यहीं रहना वीडियो तो रहना उसके बाद चले जाना ये आगे है ये पीछे है ये नेक्स्ट है और ये पॉइंटर है प्रीवियस है ये पॉइंटर इट इज रियली पॉइंटिंग আমি বলছি ডেস্কটপে করা আছে ভাই ডেস্কটপে ফোল্ডারটা কপি করে চোখ ছেড়ে দে दस से 11 हाँ जी
So, continuing with that, till the digital things are settled, digital technology is going to take over very soon. And as has been said, and everybody is saying that we should be smart enough in using digital technology, because a lot many apps are going to come up, and gradually majority of them, they will fall apart. That is my prediction. And some of them who are hardcore, like Hamilton sort of depression scale, anxiety scale and whatnot, which is going on, like PAN-SS and all, so which are going to stay back. So similarly, it is the testing time for the apps, and well, after using them and discarding them only, we will mature enough, and gradually there will be, I expect that there will be double-blind randomized control studies also on different apps, and which one is more useful, more beneficial. So that the time will only tell. So Rajesh, are you ready?
Just 1 minute, sir. I think he's still organizing. Just half a minute. It's come here.
Okay.
I wanted to hear.
So this is the high time, and as has been reminded of by everybody, that we should also be learning something from this symposium, and we should start using apps, especially the oldies. I mean, we usually stay away from the digital technology, but that is not the time now, because patients have started coming to us who are Googling the symptoms and all those things, and using the digital technology. And so we should be also be becoming smarter in knowing the application of digital technology. With that, I invite Dr. Rajesh Nagpal.
I thank the organizers, thank the chairperson for inviting me, and I invite on my own and on the behalf of my organization to the Global Congress of Biological Psychiatry, August 6th to 9th at the Aero City, Delhi. We have a track record of 4 such conferences, 4th one. Audiences are about 2,000 or so. We'll have about 25 international speakers. So Edward Moron from the University of Toro, he is also a speaker, and he's from Tunisia, he's from Estonia, and he says, current mental health services across the world remain expert-centric. They are based on traditional workflows, mostly using impractical and ineffective electronic record systems or even paper-based documentation. I just saw this video yesterday. It's a handheld device for ultrasound images of the entire body, stomach, etc. Can I have a video please on now? It works on your iPhone. It costs $999 only. It's revolutionizing ultrasound. They have an MRI also to come. It's the it's the IQ Butterfly company from the US. Can you have the video now?
This is the hottest item at the show here, the Butterfly IQ, iPhone, ultrasound probe, phone, probe. Here's David to tell us all about what is this thing.
This is a Butterfly IQ. This is a one probe whole body imaging from Butterfly Network.
And how much do these go for?
It's $19.99 with a $420 annual subscription.
All right. And show me how this thing works.
It's pretty straightforward. This is the first semiconductor-based ultrasound-on-chip technology ultrasound probe. One probe, whole body imaging. It's the broadest clearance the FDA has ever granted to one device. So what you're looking at is an ultrasound machine. It's right here in the probe. Connects up to an iPhone or an iPad, and we just announced today we are going to be available also on Android. That device actually plugs up to an iPhone, and you can see right now 19 different applications with one device. This is the first. Imagine one probe that can scan the lung, MSK, nerve, OB, vascular access. Before you'd be switching between multiple probes, you'd be spending $20,000, $30,000 for this device. Now you're saying in your hand you're able to scan the entire body. It's pretty amazing.
What we're doing here is we're demonstrating the deep learning feature on bladder volume. So we're in a bladder preset, and if we just press the tools button here and activate the tool, it'll auto-trace the bladder. And because it's a 3D probe, you can just hit calculate, and I'm not moving the probe at all. The probe's just standing still. I'm not scanning, the probe's just doing this for me. And it's gonna sweep through, it's gonna give you an actual bladder volume, and then if you want to just confirm this is actually showing you a bladder and take a look at the contour of what you just scanned, this is done for you automatically.
I always pictured the bladder as more of a balloon than the head of an alien.
Usually at the end of your shift, it's a balloon. This is a single transducer that can get you not just echo and not just abdominal imaging, where you can move over and take a look straight into gallbladder and common bile duct there, but you can take it and do linear procedures. So say you wanted to do a central line, you could come up and get straight into a linear probe.
Is there something in there that's kind of changing the frequency of the probe?
So yeah, the operating frequency is basically like 1 to 10 megahertz, and because we're not using piezoelectric crystals and instead we're using fancy technology that smarter people than I have put together, we can basically change the aperture and the operating frequency from 1 to 10. So go from abdo to cardiac to joints, nerve blocks, vascular access, whatever.
And so that's the revolution happening faster than we can think. So the topic I'm given is smart psychiatry in a digital era. So actually, we are facing a tsunami of digital psychiatry. In the next 5 years, it's going to strike us in a very, very big way. This is not working properly, please. So what is my angst? Decision making primarily based on clinical interviews, observations and self-report measures. Almost no biomarkers or technical tools have been validated. Misdiagnosis on an average, they remain misdiagnosed from 5 years to 7.5 years. These are global figures. The median time to receive a psychiatric assessment and appropriate medication is between 7 to 30 days in most EU countries, regardless of symptom severity levels. In low and middle income countries like ours, between 76% and 85% of people with SMI receive no treatment for the disorder. The corresponding range for high-income countries is also high, between 35 to 50%. In addition, patients with mental disorders have high rates of medical conditions like diabetes 45%, dyslipidemia 88%, hypertension 62%, and smoking 90%, with of course a 25-year decrease in mortality. So, this is a marriage between Engel and actually Candle. And you are all aware of the P5 system in psychiatry. We are also aware of the omics, that is the throughput screening happening through genomics, proteomics, and the works. And this is what we are now getting. It's a psychotome. So basically, it is a gene-gene connection of all genes involved in psychiatric illnesses. Edges between the node represent the known molecular interactions. So it's some kind of conglomeration finally, environment and the genes and what the actual picture is. So DSM-5 will soon be replaced, hopefully, by a more suitable classification based on current understanding. Yeah, I want to change it. So what is the wish list for clinicians looking at the tsunami of digital psychiatry? Data mining. People here see 300 patients a day. A wealth of data is generated providing service to our patients. This is usually lost as we move on to the next patient. Psychiatrists desperately need objective tests and quantitative approaches. Preventive psychiatry, resilience mutual fund, wellness paradigms, gauge from healthy populations, real time. Altering developmental trajectory of illnesses like autism and MR. Brain degeneration to actually transplant. No change occurring, sir. This, of course, all of us are extremely familiar. Vinod Khosla of the Sun Microsystems. And can you have a better changer, pointer, whatever? So, I quote, if I am to say, how do you provide the best health care for 7 billion persons on this planet at the lowest cost, and everybody on this planet have the highest levels of care, AI is the best way. Lots of data collection is the best way to do it. The possibility of AI being accepted in a remote village in India is more than an elite medical college where the gurus are sitting. Dr. Dalal, I'm sorry for that. Sequencing will cost next to zero. Microbiome will no longer be species-specific data, but strain-level data will offer even more. I must say we are stuck in the... So, the Internet of Things, which you see in the hotel here on your iPad in the rooms, gets a rethink as intelligence of things. The tech influence in human behavior will move rapidly forward with a 5G rollout. India, we are rolling out the 5G by about May of this year. Connected intelligence defines today's devices ecosystem. Over the next decade, the dynamics of connected intelligence will grow apace with the expanding 5G network, and innovative applications of AI will propel healthcare. This is from Surabhi, who writes at the Las Vegas last December. Digital health will become a way of life with evolution of sleep, tech health, wellness, and fitness. Smart gadget behavior metrics. All of us wear these smartphones and some of us wear the wearables. So the new normal is to wear a smartphone and a wearable. In 2018, humanity generated 2.5 quintillion bytes of data each day. I don't know what is meant by quintillion. In 2019 end, this doubled to the presence of Internet of Things. In the presence of this huge data load, it's easy to apply various data mining techniques to find behavioral patterns and zoom into personalized data generation behavior. This is digital phenotyping or smart gadget behaviorometrics. So what is the relevance of phenotyping to our patient population and our work? Finally, we are going to have quantitative data in large amounts. Real-time monitoring of patients and their response to interventions. Diagnosis of traits of developing psychiatric symptom episodes. And more interestingly, providing a window of opportunity and real-time intervention at the crucial time interval when a trait shifts into a state, thereby preventing acute episode. So the prodromal into the acute. And of course, the various devices like your PCs, your laptops, your smartphones, your other products, and your iPads, tablets, and huge number of in vivo biosignatures you see there, all of them. And you have the gyroscope, you have the flashlight, the primary screen, you have the Bluetooth, off-board sensors, on-board sensors. And of course, this is of course the mHealth system architecture, which basically serves the entire purpose. And there is today a free to download BV platform, digital phenotyping for all, from India to the US to everywhere. BV is the leading open source digital phenotyping research platform designed for the collection and analysis of research-grade raw data from smartphone sensors to usage logs. The first part of BV is free for access for all of us. Digital technology will eventually lead to informed public health policy, something much missing in the Indian landscape. The data-driven RDoc is an attempt to create a new kind of taxonomy for mental disorders by bringing the power of modern research approaches in genetics, neuroscience, and behavioral science to the problems of mental illness. INCEL said these prophetic words in India and left and joined Google after that about 4 years ago. Digital technology will facilitate diagnosis, prognosis, prediction, treatment selection, delivery, disease monitoring, and optimize the allocation of healthcare resources, all of which can be utilized to informed public policy. What is ambient intelligence? The iPad in my room in this hotel is a reflection of ambient intelligence. It connects everything around me, the light, the speakers, the TV, the food I order, all done on a click of the iPad in this hotel. And that's the kind of stuff that is happening in this hotel. Now, ambient system and the Internet of Things. This starts behaving
as an integrated system of general environment intelligence that assists and helps the human beings who are living in the environment. The relevance to us, ambient intelligence excels in caring for assisted living and constant monitoring of various psychiatric patients. There are 2 robots available which can catch falls of patient, psychiatric patient, going to the bathroom. You can prevent the fall by anticipating it by using ambient intelligence. Digitally phenotyping of the human interaction and behavioral elicitation of various patterns leading to newer symptoms and newer diagnosis. AI and psychiatry. Dr. Bhaskar suggested this format to me for this part of the presentation. Automation intelligence, specific deep learning artificial intelligence of single or limited scale modalities, and true deep learning general artificial intelligence. So talking about automation intelligence. Automation which uses algorithms, which you know are crucial for almost everything that we are doing today, perform 4 classes of functions: information acquisition, information analysis, a decision action selection, and action implementation. They can be used in various areas: psychotherapy chatbot, basic surveillance bots for monitoring all treatment care and aspects, robotic automation serving as first contact physicians, various novel psychotherapy interventions like the avatar therapy. Avatar therapy, of course, is a mixture of various approaches. Analytical algorithms for superficial but constant behavioral analysis. This was launched about 2 weeks ago in the US at the Las Vegas, and these are almost human-like. They had 6 of them there, and that's the neon avatars. They came with a lot of hype, didn't perform too well, but still the picture came through and they could afford to speak. But apps, as we all know today, and the discussion between is, are passé. DT is being defined as a broad area including virtual reality. The US FDA approved the therapeutic application of DT in the psychiatry field promptly, such as for addiction. This promotes a quicker and more aggressive clinical application of DT. The VBot chat would actually hear and offer evidence-based CBT. Users interact with the VBot via instant messaging app, and these conversations are reviewed by a trained psychologist. VBot's natural language is modeled after social discourse, and response function decision trees are trained in CBT in 6 key processes. Process-oriented treatment features: empathy, personalization, goal setting, accountability, motivation, and reflection. And the most important aspect, which actually picked up in the RCT, was that the reported feeling was you're talking to a person who expresses real person concern. And you have the Reset 3, which is the first FDA-approved digital therapeutic. The Reset is a mobile app adjunct therapy for substance use disorders, abusing alcohol, coke, marijuana, or stimulants. Reset does not appear to directly utilize big data or machine learning for therapy delivery. It collects the type of patient data that could be leveraged to improve treatment prognosis. Emma speaks Dutch, designed to help mild anxiety. Kareem speaks Arabic and assists Syrian refugees struggling to cope after the war. X2A1, the startup which designed both, is now showcasing tests. Tests can perform CBT as well as purportedly improve the burnout associated with caregiving. So moving towards AI-based rehab systems, Ginger.io combines machine learning and a clinical network to provide the right level of emotional support at the right time. This platform offers 24/7 online CBT, mindfulness, and resilience training. On downloading the app, users get matched with a dedicated team of 3 emotional support coaches, and to help them when needed, the user may be escalated to licensed therapists through video consults. I'm sorry. But there has been no parallel explosion in RCTs examining mindfulness apps. App Headspace, which all of us have seen and used, is a 6-week intervention in the undergraduates, offers no benefits on well-being, affect cognitive function, or mindful abilities. This is revealed through within-subject pre-post analysis or in comparison to active control. The app Wildflower is a 3-week intervention in the UG students. It benefits well-being and stress resilience. This is revealed in both in-subject and analysis as well as comparison to active control. Wildflowers leverages computer vision to extract heart rate variability through photoplethysmographic imaging of users' selfie videos. Now, one interesting thing, India is going the US way. We are going to have smaller families, nuclear families, and lots of social isolation. So, Moderate Online Social Therapy Project has a cafe section where users can share experiences. Users can also nominate a problem in the Talk It Out section, where problems get solved in a group, or they can engage in a behavioral task that uses mindfulness and self-compassion in a Do It section. Currently, human moderators are looking at innovative AI solutions. And this is Simon Alfonso from University of Melbourne. Monitoring compliance, one big bugbear in psychiatry. Bickmore tested an automated system, included an animated agent, which conducts simulated conversations in order to promote medication adherence in individuals with schizophrenia by establishing emotional relationship with the patient and providing consistent social support. They conducted a 1-month pilot study, and the agent inquired about medication adherence, provided tips and suggestions for solving adherence problems. They found the agent was successful in increasing the rate of adherence among participants. There is some desi potpourri also. Jain et al. Reported that increased access to mobile phones offers new opportunity and service delivery in India in regions where mental health resources are scarce and the treatment gap is large, which is almost 80% of the country. An innovative model developed by Savita Malhotra from PGI and a group suggested combining medical informatics for clinical decision making and video control for training of the patient in the use of training of the primary care physician in the use of deciding and video consulting if needed, and that has been implemented for the last 2 years. So I come to the second part of the presentation, that is specific deep learning artificial intelligence of single or limited skill modalities. Learn to understand new patterns unsupervised by any human being, usually one modality and occasionally multiple. Relevance in psychiatry. Working in image processing, reading and understanding various minute and complex changes in imaging. Detecting various and reproducible patterns in disorders that will help us in diagnostic, therapeutic and prognostic classification and stratification of symptom profile. Finding and matching bioinformatics, omics and gene ontology data for any sets of syndromes in psychiatry, what I talked about the psychotome. Discovering best possible treatment avenues in a set of patients based on patient data alone. So machine learning to detect or predict depression. Choice of the most suitable data is complicated by our current lack of a unified pathophysiological understanding of the illness, our current lack of markers, and the heterogeneity of the system. Current trends involve using multitude of data, including sensors, example, movement patterns from geolocation, and the gyroscopic data from mobile phones. Behavioral data, example, semantic content analysis of social media entries. Clinical data, example, depression, rating scales and questionnaires, and neuroimaging data. Big data has begun to now roll in. Neuroimaging, including computer-aided tomography, structural and functional MRI, MRI-based DTI, PET, and MRS have now overtaken. Electrophysiologic methods include extracranial and intracranial EEG, magnetoencephalography, genetic and epigenetic information, or more generally, omics mapping approaches from genome and proteome to interactome, biomarkers from blood, cerebrospinal fluid, and tissue samples. So that's the kind of program which you have machine learning on one hand, you have the EMR data, you have the image data, clinical activities, clinical notes in human language, natural language processing, and artificial intelligence. A complete interface. That's the robo which is now seeing images. And now you have some robos. The VGO teleoperated robo. VGO provides a means for obtaining health information, improving older adults and daily functioning, and giving peace of mind to family members who live remotely. The VGO robo can be controlled locally through a handheld controller or remotely over the internet. It has a camera, microphone, speakers, video display to establish a video communication and connection between different locations. Caregivers can access the VGO system to monitor the elderly person's well-being. And that's the robo here. Victoria Home Television Repo. The system includes an activity monitor, a fault detector I was saying, an automatic pill dispenser, and a mobile telepresence robo. So all in one, a good caregiver. A smartphone app for family and friends, providing a general overview of the elderly person's well-being is provided. Professional caregivers can use system to monitor the user, and that's how it works. Paro, the seal robo, it's a very popular robo all over the world today, and a very cute one at that, is an interactive baby seal robot developed by Takanori Shibata. Paro interacts with people as if it is alive, moving its heads and legs and making sounds, imitates the voice of a real baby seal. Paro has been used as a therapeutic robo for people with dementia in Japan and throughout Europe since 2003. And that's how it looks like. Actually moves. The Reba. The Reba is a nursing robot that is able to lift a person from a bed or a wheelchair. It's one of the most physically challenging tasks in nursing care. Can lift a person of 150 kilos weight also. And now a robotic cat to look after mom. While robots that take care of elderly are on the rise, many question the ethics of such products. I have not discussed the ethical issues of AI. So the last part is true deep learning, general artificial intelligence. Human intelligence, comparable artificial intelligence, can understand about, learn from, and improve upon all modalities of information. This is what we have been dreading for a long time. Lower, same, or higher than human intelligence will understand the concept of self, and while taking dynamic decision on, it will be able to figure out the role of itself in that process, the hallmark of human intelligence. Will be able to do anything a human can do. Uses are simply infinite. Robotic psychiatry. This artificial intelligence, which is encased in the body made of artificial DNA and genetic material, will develop a robotic equivalent of various human diseases. All will need all human medical specialties. Sigmund Freud will turn his grave given this kind of a caregiver and a counselor. Finally, this is not science fiction. The International Network for Digital Mental Health is comprised of top-level clinicians, regulatory and ICT experts, genetic scientists, and support organizations. At the Congress in the August Delhi, Edward Moran, who heads it, will be there and inform us further. The IDMHN, which is their organization, has been formed to enable the implementation of digital innovations in clinical practice, hereby facilitating the transformation of current mental health services to be more personalized and be responsive to patients and healthcare needs. Their eye approach seems to follow global patterns from Europe, US to India, Bangladesh, and Syria. And that's what it looks like in routine practice. You have the biobank, the drug-drug interaction tool, e-prescription system, EMRs, National Health System, the patient portal. What we call that today as CapEx in business, but it's all infrastructure. You have the iApproach Cloud, which is algorithms on genetic data, documental, digital phenotyping, big data store, which is anonymized for ethical reasons, the knowledge-based, prediction modeling, impact evaluation, and deployment. These appear to be working very fast. And I thank you for the presentation. Dr. Madhukar was supposed to take the next half, so I've just done my half of it. Thank you, sir.
Thank you, Rajesh. You can have a seat. Ladies and gentlemen, we have heard a very futuristic presentation by Dr. Rajesh Nagpal, and I hope that these all gadgets are going to make our lives easier. The time will tell. And let us have some questions, comments. Yes, sir.
Dr. Santosh Mudolkar. Hi, Dr. Nagpal, it's a very interesting presentation. Do you think now India is ready to develop a digital strategy? Because in UK, there is a NHSX, which is the national organization looking at AI, use of AI technology in the NHS. And I did a similar presentation yesterday on AI. Do you think India now needs to look at it nationally to have a strategy? Because the advantages are there, but then who's going to store the data and privacy issues and all those things which we are all aware after the Cambridge Analytica episode, really. So, Your thoughts on that, please.
Tinder there. Data has become very sacred. There is no finite way to keep data with us, and we do have to look at solutions which employ many agencies involving data. We are already getting on that bandwagon, already begun talking with the government of India. Our area is only mental health, so we're focusing on that. But your point is well taken, sir. We are now ahead in the game, hopefully.
Dr. Rajesh Nagpal, I think it was a wonderful presentation, but we should have, covered a little bit the negatives. We are covering the positives. And the question is that how do we educate our PGs about it? I don't know any place where they are teaching it. And it doesn't help when we start teaching once it's already engulfed us. And the patients also don't get the, the benefit. And another thing is, I would refer to a very short movie by Satyajit Ray called Anukul. And I think it's around 11 minutes or 10 minutes, and it shows what can happen. I'm totally for digital technology, although I'm asking you to please see that movie. I've sent it to you already.
Yeah, so about 3 years ago, we had the demonetization, and we in India suffered a great deal. But the deal was simple. The deal was that we are putting everybody into this water. It's a large pond. You can either swim or sink. Many of us sank. We became poor. We had suicides, divorces, etc. Some of us swam forward and do businesses. In a similar sense, my sense is, and I'm not some kind of Nostradamus, that this is a tsunami. Whether we like it or not, prepared or not, this is going to come. It's a matter of time. 5G rollout means we are on top of everything. Germany, some parts of US are thinking of not having 5G. We are going to have 5G here. We don't have a choice. The smartphone was not a choice. Today, a young child having game addiction, the biggest problem, how to remove the smartphone. You can't do that anymore. I am treating 6 of them, you can't remove the phone. They get angry, they get depressed, etc. The point, we don't have our children have to start learning. And my sense is they're going to adapt much better than us, to my mind.
So my question, I am Dr. John from Kochi. My question is more of philosophical than of technical. You gave a very wonderful lecture on the future, and it's, but we are not taught about the implications. In few years, I also believe that the AI will be as capable as psychiatrists. But then what will we do? And then secondly, will that intelligence or that beings, the next level of evolved beings, will consider it necessary to treat the mental patients? We are not worried about the psychology of the animals. Thank you very much. And this is something which we have to think before we, before this juggernaut. At least now it can be stopped. But I'm very sure that in 2 to 3 years, it will be beyond us to stop it. Thank you.
Sir, they are lovely inputs. They are worthy of think tank. I have to think about them. You're right.
So I am Dr. Niranjan Prasad from Kannur. There is a part in Kerala, and it's very, very hot there. And what I'm going to say is that world is not same all over. And in the West, it is very, very cold, and they are not able to take sodium because they have to avoid sodium taking at all. But in our place, we need to take sodium so that we can bear the sun. That's the thing. So the artificial intelligence, if it is working there, it may not work in our place. That's what we have to think. We have to incorporate this part of sodium in that, then only it will be working in all over the world. That's what I want to say. It is different in, see, if you look at people who are staying near equator, they are smaller and thinner than us. If you see patients, people in the Canada, they are very tall and bigger than us. That is only because they have excess of sodium in their body when they are growing up. If we give sodium to young people, they will become bigger and stronger. And that's what we have to study and do in the future. That's what I think. Thank you.
I completely agree, sir. The Toyota Accord car adapts from Japan to India and then to the US depending upon the road conditions. AI also will, of course, adapt itself. I completely agree with you. We have to adapt.
Yes, sir. Yes. I am Dr. Neto from BJ Government Medical College, Pune.
Actually, I would say that this has already taken over us. In our department, we have a company that has already tied up, and we the psychiatrists are giving them the diagnosis. So they are trying to do voice samples in patients of depression. So the company is, we diagnose the patient and we give them the patients, and they take the voice sample and they do the interpretation by their methods. So I think it requires, both of us, both should be involved, the technology and the physician together.
Thank you, sir.
Yes, anybody else? Yes, please.
Hi, good morning. My name is Dr. Pathak from New York. So, very wonderful presentation, actually. But I do have one question, and that is in the context of public policy and public health. I think some of these technologies are disproportionately going to affect people from the lower class of the society, and they may be less privileged, and as a result, not being able to afford getting an epigenetic analysis done or a microbiome analysis done. So in conjunction with the technological revolution, the picture that you're painting, I think there has to be very strong policy making to make sure that these approaches are fair and equitable to all sections of the society and not just one portion of the society.
Point well taken, sir.
Yes. Anyone else? Yes?
I'm Dr. Bhattacharya from Canada. Do you predict that computers will be able to empathize with us at any point? Do you predict that computers will have empathy?
Yes, sir. The avatars are now, I showed you that particular RCT in which they have begun to put in programs empathy, and then in the machine learning process, they begin to develop empathy on their own. So the program overrides. That's what we saw even in the chess games also, sir. You taught them one chess game and they improvised to about 100 others. And they began beating the human beings.
Do they differentiate factual empathy from emotional empathy?
Interesting question, sir.
Thank you.
If there is a program inbuilt. By itself also, yes. There is some evidence for that too, sir. Begun to happen. I said yes.
So, if there are no further questions and we are about time. So it's a wonderful presentation, Dr. Nagpal, and we all learned quite a bit. And in India, I would say that there are some people that NIMHANS is working on it, and All India Institute of Medical Sciences, New Delhi, in the substance use, they have come out with some apps to be used. And NIMHANS is using the platform for teaching all over the country. So all these things have started beginning in our country. It will take a long time, and we are all waiting very patiently for the, I would say, the exciting time through which we are going, and as predicted by Dr. Nagpal, that in 5 years' time we'll be having the tsunami, and then it will gradually settle down. Thank you.
I would like to request our chairperson, Dr. P.K. Dalal, to honor our speaker, Dr. Rajesh Nagpal. So. Yes, sir, yes. Unfortunately, our next session from 11:15 to 12:15 get cancelled because we haven't reached to Dr. Nachiketa Sinha. So the next session will start from 12:15 and it will be till 1:15 on the topic autism spectrum disorder, ASD.